All right, transitive fusion. Light's criteria for transitive fusion is the fluid collection does not meet any of these. So these are going to look real familiar. Pleural protein, we talked about it, with the ratio of the pleural protein. So pleural protein divided by serum protein greater than 0.5. Pleural LDH divided by serum LDH greater than 0.6. Pleural LDH greater than upper 2/3 limits of normal of serum LDH. It does not meet any of these. It's going to be transitive. So what's an example of a transitive? Is going to be cirrhosis, heart failure, nephrotic syndrome. So let's go back over here. And what can be causes of exudative effusions? Pneumonia, malignancy, pancreatitis. These can be causes of exudative effusion. Let's go back. Transitive effusion did not meet any of these criteria. So now what happens if you take diuretics? How can you change what can you do to adjust? Ongoing diuresis may lead to misclassification of transitive effusions as exudative. A serum protein to pleural protein ratio exceeding 3.1 suggests a transitive. So you change up your ratios, meaning let's go back. The greater than 3.1, so pleural protein, serum protein greater than, instead of 5.0, greater than 3.1. 3.1. So let's go back to that again. Ongoing diuresis may lead to misclassification of transitive effusion as exudates. So using a different cutoff, a serum protein to pleural fluid protein exceeding 3.1 suggests a transidate. A serum albumin to pleural fluid albumin ratio greater than 1.2 indicates a transidate. So this is when you would get the fluid albumin levels if the patient is being diuresed. So you would get the fluid in your serum. Empyema, what is this? Complex parapneumonic effusion. What is the pleural fluid characteristics? pH below 7.2, glucose levels under 60 in the pleural fluid, white blood count exceeding 50,000, elevated LDH levels due to neutrophil lysis. So you can have, say we pulled this fluid out and the culture was negative. So bacteria can be easily cleared from the pleural space. It can be, if you give, say for example, is we couldn't get the thoracentesis and do it right away. So you have to treat them. Nowadays is they're getting antibiotics as soon as they hit the door in the ER. Am I saying anything against it? No, but it's just a fact of life. So they can be inoculated before you even see the patient. So the pleural fluid can usually be cleared of bacteria pretty fast once they receive antibiotics, anywhere from a few hours to a few days from antibiotics after antibiotics were started. So if you have an empyema, so you have the pH is below 7.2, the glucose level is under 60, your white blood count is exceeding 50,000 on your pleural sample, and the elevated LDH levels due to neutrophil lysis. What do? You want to put a chest tube in and you want to give antibiotics. And then you may need to consider surgery if failure to drain with a chest tube. And you can talk about this with the old school thoracic surgeons. They'll tell you when they have these complicated effusions that they can get this fibrosis in there. And they equate it to is like scooping out a pumpkin. As you're getting that pumpkin scooper and you're scooping out this fibrosis from these infections that can occur in the lungs. Diseases which can cause low pleural fluid glucose concentration. So to help to get the diagnosis, rheumatoid pleurisy occurs in 5% of patients with rheumatoid arthritis, often accompanied by a pleural effusion. The pH is typically low at 7.3. So they can have diseases that have low pleural fluid glucose concentration. Rheumatoid arthritis is one. Tuberculous pleurisy, lupus pleurisy, malignant effusion, esophageal rupture can also have low pleural fluid glucose concentration. Pleural protein. So if you have high pleural protein, you've pulled out that fluid, and TB can have this. Waldstrom's, macroglobulinemia, and multiple myeloma can have when the protein is in the 7 to 8 gram range. So these are diseases that can have high pleural protein. Chylothorax is milky white fluid. When are you going to see this? when you have triglycerides greater than 110, or disruption of the thoracic duct can be through trauma or line placement. Non-traumatic is from malignancy, sclerosis, retrosternal goiter, TB, or fluorosis. Traumatic, putting a subclavian CVC, subclavian CVC, and esophageal surgery. These can cause chylothorax. Pleural fluid creatinine. So when you have, you pull the fluid out and it has a high creatinine, what can you think of? Is a urothorax, when the pleural fluid serum creatinine ratio is greater than 1, meaning that you may have a conduit where urine is actually, can you imagine that? You're getting pee in your lungs. That doesn't sound great, does it? I got pee in my lungs. What happens if we have a low pleural fluid pH? So you pull the fluid out and you send the pH to the lab, and it's less than 7.5 or to 7.2. These are going to require pleural space drainage. As we talked about, the empyema is putting a drain in. Elevated pleural fluid amylase. What can cause this? Pancreatitis or esophageal rupture. So you pull out the fluid and you check the amylase level, and it's elevated. Lymphocyte predominant pleural effusion, TB, and malignancy can both do this. Now let's talk about pleural fluid cytology. Now this is a good board question. It's a good real life question too. So when we pull that fluid out, we can detect malignant cells up to about 60%. So we pull the fluid out, we get about a 60% success. Second sample may increase by about 15%. 3 different thoracentesis can detect up to 90% of malignant effusions. So what is a board question going to ask you? On board question, the first sample is negative. What do they want you to do? You're going to think about it. They're going to give a lot of other good answers. They may even talk about starting some sort of chemotherapy on a condition that you suspect has already been diagnosed by reading the question. Or they can say is, can you do another thoracentesis? That is going to be your correct answer. All right, 19-year-old male with asthma exacerbation. Asthma exacerbation, I want you to think when you say asthma exacerbation, I want you to think that you're going to make a little pee-pee on yourself. I want you to get nervous about asthma exacerbation because usually these are younger people. This is a 19-year-old male. They have a lot of life to live, and guess what? They can die from this. Now, we're getting better at treating asthma, but they still can die. So in the United States, adults, about 8% of adults have asthma. Children have a higher preponderance of asthma, about 10%. In the United States, it costs about $56 billion annually for asthma treatment. That includes medical expenses, lost productivity, and disability in these patients. And guess what? In 2021, about 3,500 people died from an asthma exacerbation in a U.S. hospital. That's pretty scary. This is a scary disease because, and I think, oh, you're like, oh, it's just asthma. Once you see a severe exacerbation come in and you're having to treat this patient and you're worried they're going to die. So whenever in a board question and in real life question, if this patient is taking an inhaler, you say, hey doc, I'm taking the medications, I'm still having asthma, I'm still having COPD. What is the answer for real life and for boards is, guess what? We're not great about teaching how to use an inhaler. Errors in inhaler use can impact drug delivery, meaning if we do the inhaler wrong, instead of getting into the target tissue of the lungs, it goes into the stomach and it doesn't work. So in the study is 45%, so they went and they watched the way patients did their inhalers, and they said that they knew how to use their inhaler and they were doing their inhaler properly, and they believed in all these things and they did everything right. Only 45% of these patients use their inhalers, 45% use them improperly. They use their inhalers improperly. So this is a great board question because these patients are paying for these medications, so instead of hitting the target tissue in the lungs, they're hitting a non-target tissue in the stomach so they can get side effects from these medications without the benefits. This costs the system. So remember, we have all these people getting sick from asthma, and it's a high cost to the system because they have lost productivity, they have high hospital costs, and if they can be prevented, if they just learn how to take the medication that they have in their hand properly. Very important. Very important too is asthma and pregnancy, you still use the standard asthma treatments. No changes at all. Now let's talk about the Mandela trial. In the Mandela trial, it was answering a question that we've had for years, is what's the right rescue medication for patients with asthma? And we already talked about how asthma can reduce productivity, can increase costs, and there's a risk of death. So we want to avoid patients getting into the hospital. We want to avoid from getting sick. So what is the right in these patients with moderate to severe asthma? What are our choices right here? In this study, we use combination of budesonide, albuterol inhalers, or albuterol, which has been the standard of care for many years, albuterol alone. In the high dose, it was albuterol 180 micrograms and budesonide 160 micrograms. And then the low dose combination was albuterol 180 micrograms and budesonide 80 micrograms. And the control was just 180 micrograms. So the risk of severe asthma exacerbation was 26% lower in the high dose, okay? This became the winner. The winner. This is a change in dogma. This is an important study. This is a study that recently came out in 2022. This is going to change things, all right? I know that we're 2025. It takes time for things to be adopted. Remember, there was reduced exacerbations. There was lower corticosteroid use. As we also talked through several of our lectures, how corticosteroids have caused these side effects and they can affect the body systemically. So this was a great study. And what was a severe exacerbation? Was defined as an asthma attack requiring systemic corticosteroids, a hospital stay, or emergency room visit. These are all things that we want to avoid. And by changing up what our rescue medication is, we can help these patients avoid the hospital, avoid having a prolonged hospital stay, and avoiding taking corticosteroids. Intubation in an asthma patient. During a severe asthma attack, the patient initially hyperventilates and the CO2 is low. And after a while, the patient, they're running a marathon with their lungs. Just think they're running a marathon with their lung. As the chest wall and diaphragm muscles fatigue, the patient starts to breathe more and more slowly. And then they're going to have a normalizing of the PCO2 and finally become hypercapnic. So when you get a board review question that says, hey, and they're showing the labs and it's a normal PCO2, what should you say? What would the answer be? Among those answer choices is going to be intubate that patient, because they've been breathing fast, and they should have low CO2 initially. Then they get tired. They're tired of running that marathon with their lungs. The CO2 becomes normal. So you may feel this is a trick on the question, on the answer stem, and you're like, oh, that can't be right. It's a normal CO2. No, they're starting to wear out, and you need to intubate the patient. That's a great board review question. It pops up in multiple boards multiple times. So mild hypoxemia and hypocapnia are normal with acute asthma attacks. Normal capnia and hypercapnia indicates impending respiratory failure in need for intubation or non-invasive ventilatory support. That's a BiPAP. In the past, it was told to avoid BiPAPs. This has changed, and we should use the term BPAP. That's the generic term, BPAP. So in the past, we were told to avoid BPAPs, but now they're used for treatment of asthma. If intubation is required, we need to first sedate and then maybe paralyze only if needed. We want to avoid the use of neuromuscular blocking agents to avoid prolonged blockade, because that means to longer hospitalization, muscle weakness. We want to avoid morphine because it may cause a histamine release. Once intubate, we want to get our numbers up and we want to get our pH up, but we don't want to do it too quickly. These patients, remember, inspiration to expiration, they're going to have a long expiration period. So remember, we're doing our inspiration and our expiration. Normal is going to be 1 to 2. These patients may be 1 to 4. So the first part of inspiration, we're breathing in, and then the second part is going to be longer on patients with asthma. And remember, if we put the ventilator too fast, they're going to have a breath stacking because they have not fully exhaled. They breathe out in, and then as they breathe out, a new breath comes in, and a new breath comes in. And so what happens when we have breath stacking? It can cause decreased venous return, barotrauma to the lungs, because you're ventilating against basically a lung that's not ready to be ventilated. You're going to have decreased venous return. So you're going to have decreased filling pressures, decreased cardiac output, and hypotension, and poor perfusion of the vital organs. So very important that we don't overventilate these patients. So what can be an asthma mimic? And this can be vocal cord dysfunction. and I'll talk about some personal experience in watching these patients. So you have clinical suspicion for paradoxical, what is vocal cord dysfunction? So when I'm talking right now, my vocal cords are opening up, okay? And when vocal cords dysfunction, you're gonna see this abduction, so AB and adduction. Adduction, we're adding together and we're closing up, okay? These patients, instead of abducting, they're adducting. So it's a paradoxical vocal cord fold motion. It's a dysfunction, and you suspect this when the patients have, when they have difficulty in speaking. So this is a patient where you're treating for asthma and they just don't get better. Or this is a patient where they've been intubated and you pull the tube and you hear this stridor or wheezing and you're like, you have their stridor up and you hear it more up here than you do in the lungs. So how do you diagnose this? This can be difficult to diagnose. They have to get your friendly ENT doctor, and you're going to want them to go through the nose, and you're going to use a laryngoscope, and you're going to look down in through, and you're going to look for see if the vocal cords are abducting, adding together instead of spreading apart when they should be. The symptoms respond only partially to asthma medication. So you get that clinical suspicion is you have a picture of asthma and you're like, man, these medications are not working. They're not working. They also can have stridor, difficulty breathing in. So what's the treatment? The treatment can be, they need to have speech therapy. And also treatment of their GERD may help them improve. On the PFT, we'll discuss the PFT. The PFT itself can be normal, but there can be flattening during the inspiratory cycle. We're going to go through PFTs. And remember, the most important thing is being able to visualize, and they'll get the fiber optics, the ENT will go in there, and they're going to show the vocal cords are abducted. I know I keep saying this, but this is an important point to remember. And you have a paradoxical vocal cord fold motion. All right, so if a patient has asthma, and they can have an increasing lactate. Does that mean they have infection? Not always. We've already discussed on asthma, we've already discussed on pyruvate to lactate. Okay, so from pyruvate to lactate, we have lactate dehydrogenase. Now I know we're kind of conditioned that lactate is horrible and that people are gonna die. Lactate is a fuel that we use in our body. And if we took you and we ran you up a flight of stairs, remember I discussed this? You ran up the flight of stairs, you feel you're gonna die, but you're not gonna die, you're gonna have an elevated lactate level. If I took your lactate level at the bottom of the stairs and I ran it up the stairs, you ran up the stairs, you took it. Another example is if you can go and look at old Tour de France videos. You look at where Lance Armstrong was riding his bike in there. And what they would do is they had a point of care lactate measurement. God only knows what they were doing. I guess they were probably giving him certain drugs. But if his lactate pops up, they were giving him certain treatments for this. So, and then you can look at some of those videos, you can see Lance Armstrong's lactate was 10. He wasn't dying, he was winning and riding up the French Alps. So lactate is a fuel. Yes, we need to be mindful of it because it can show signs of poor perfusion, but sometimes when the pendulum swings too much in medicine and we don't sit and think about it and it goes, oh, okay, this lactate is elevated for another reason. We're gonna talk why it's elevated in asthma. So beta-adrenergic, these increase pyruvate production. What are some medications that can do that? Is albuterol inhalers can do this. So we have glycogen and glucose, then glucolysis to pyruvate. So we're gonna, beta-adrenergic are gonna increase our pyruvate, okay? And our pyruvate converts to lactate. So we are gonna have increased lactate from the medications, the albuterol inhalers. Just remember, the excessive pyruvate in the Krebs cycle goes to lactate. So this is what's happening. Also, the fact is they're probably getting steroids, and steroids increase the number of beta receptors in the tissues. That's the purpose of giving steroids in an asthma exacerbation, is you're cooling things down and you're increasing the number of beta receptors in the tissues. So you have a patient that you have suspected COPD. You're on your wards, you're in the ICU, or you're in clinic. What do? The only way to really get a diagnosis is getting what? A PFT. And this is an example of a pulmonary function test. Here you can see this is where the tech is going to sit. Here have the printer here to print out what the results are. They have some tissues for the patient to cry. But also right here, this is the most important thing. This is the box for where the patient is going to get in, and they're going to do these tests. And what is the pulmonary function test? Let's think about it as an echo for the lungs. We're learning about what's going on with the function of the lungs. It's not like we can cut out the lungs. Well, we can cut them out, but it's hard to put them back in. So how can we see inside the chest and to figure out how these patients' lung function is? This is a test that works well. What's really important is this person sitting here, right here, yeah, the human person sitting here, they need to be excellent, okay? They need to be able to get the best they can out of these patients, because you're going to see where there's pulmonary function tests where they don't have a great tech. It's not IAI has not taken over for this yet. And you need to have somebody that needs to get this patient responsive so they can take the breaths in like they need to. They need to be able to give a good response to what the tech is saying. And you can tell the difference between a tech that's good and bad is they really can encourage the patient. You'll literally hear them down the hall yelling all day long to get these patients to get these deep breaths in so we can get good testing results.